vulgaris is a chronic inflammatory conditions involving pilosebaceous unit. Pathophysiology of acne vulgaris is the onset is usually seen during puberty, that is between 12 to 20 years of age. It is seen in around 80% of adolescents, and comedones we see in 100% of individuals. Some individuals, this may progress on to third and fourth decade of life. Coming to pathophysiology of this condition, we have androgens during puberty, secreted during puberty in both males and females. These androgens increases the sebum secretion, and also they induce keratinization of keratinocytes at infundibulum, that is proliferation of keratinocytes at infundibulum, causing hyperkeratinization and blocking of this infundibular area. So after blocking of this area, there will be pooling of the secretions here, and then there will be due to blockade and pooling of the secretions, there will be anaerobic conditions. Due to this, Norman's commensal of skin like Cutibacterium acnes or Propionibacterium acnes will proliferate, followed by proliferation of this bacteria nicely inside this pilosebaceous unit. This bacteria will produce lipase, which break down triglycerides present in sebum to free fatty acids. The free fatty acids present inside this pilosebaceous unit is inflammatory. Thereby, it causes chronic inflammation and the clinical manifestation seen in acne vulgaris. The factors modifying acne vulgaris are hot humid conditions, because the cells get swollen up during these conditions, exacerbating the disease. The diet, we have high glycemic index food and milk product, causing increase in IG of1, insulin-like growth factor 1, which causes blockade of the sebaceous duct. The stress, emotional and psychological stress also exacerbate the condition. We have genetic predisposition and hormonal changes also influences this. In premenopausal, we see premenopausal flare of acne in 70% of females. This is due to relative androgen excess. In PCOS, also due to androgen excess, we can see acne vulgaris. Then coming to clinical manifestation of this condition, acne vulgaris, we have seborrhea. Usually we see greasiness of skin in these patients. We see comedone, that can be closed or open comedone. The lesions in this condition, acne vulgaris, is usually seen on face and also be seen on chest and back region. Comedones are the blocked pilosebaceous unit, causing pooling of the secretion here. So if this block is not open, then it will be white comedone. If it opens, ruptures and opens, it causes oxidation of the contents of this pilosebaceous unit, causing black comedones. This is about white and black comedones. In this image, you can see black comedones here. Then, due to inflammation, as I mentioned, the free fatty acids conversion by lipase causes inflammation. We see inflammatory lesions in case of acne vulgaris. Those are erythema and papules in grade 2 disease. The comedones has been classified as grade 1 disease, whereas erythema and papules, here you can see erythema and papules, erythema along with the raised regions less than 1 centimeter is called grade 2 disease. If we have pustules in the patients, it's called as grade 3 disease. If the patient has cystic and nodular lesions, here you can see cystic and nodular lesions, it is called as grade 4 disease. We have management of this condition. Investigation, no need, because it's a clinical diagnosis. The management is, we use topical agents like topical retinoids, tretinoin and adapalene. This topical retinoids is keratolytic. Along with that, it reduces the cohesion between the keratinocytes, thereby helping in treating the condition, and also it's anti-inflammatory in action. So topical retinoids like tretinoin and adapalene can be used in this condition. Topical antibiotics like clindamycin and nadifloxacin can be used, because we saw pathophysiology, the Propionibacterium acne proliferation is there, which is causing release of lipase and inflammation due to production of excess of free fatty acids from sebum. So we can give topical antibiotic to deal with this condition. And also we can give topical benzyl peroxide, which is a comedolatic and antibacterial drug. We give systemic therapy if the patient has severe disease. Systemic antibiotics like doxycycline and azithromycin can be given. Retinoids like isotretinoin is given in nodulocystic acne, that is grade 4 disease. And if the patient has therapy resistance to topical therapy, we can give systemic therapy with retinoids like isotretinoin. This is about acne vulgaris. To summarize, acne vulgaris is a chronic inflammatory condition involving pilosebaceous unit. The etiopathyphysiology of this condition, it's seen at puberty, that is between 12 to 20 years of age, in 80% of individuals. In some individuals, it can progress to third and fourth decade. Pathophysiology, we have androgens causing increased sebum secretion. It provides anaerobic conditions and Cutibacterium acnes or Propionibacterium acne proliferation, which releases lipase enzyme, which converts triglycerides to free fatty acids, thereby causing inflammation. The factors modifying the disease are autoimmune condition, diet, that is hyperglycemic agents, and milk and milk products, emotional, psychological stress, genetic agents, and hormonal conditions. Clinical manifestations, we have the lesions in face, chest, or back lesions, that is comedones, that is grade 1 disease. In grade 2, we have erythema and papules. In grade 3 disease, we have pustules. In grade 4 disease, we have cysts and nodules. Management of this condition, we have topical agents like topical retinoids like tretinoin and adapalene can be given. Topical antibiotics like clindamycin, nadifloxacin can be given. Systemic therapy like antibiotics, azithromycin, doxycycline, and isotretinoin can be given.